Hi, this is Merrina again. Welcome back, and we are going to continue reading Better by Atul Gawande. So, this time we're going to read chapter 7. It's called The Doctors of the Death Chamber. Last time we read chapter 6 called Piecework. It talked about how much doctors should get paid and whether they're supposed to treat all patients or only choose patients who can afford them. So today's chapter seems interesting. I wonder what it means by saying doctors on the death chamber. Let's read to find out. On February 14, 2006, a United States District Court issued an unprecedented ruling concerning the California execution by lethal injection of murderer Michael Morales. The ruling ordered the state to have a physician, specifically an anesthesiologist, personally supervise the execution or else to drastically change the standard protocol for lethal injections. Under that protocol, the anesthetic sodium thiopental is given at massive doses that are expected to halt breathing and extinguish consciousness within 1 minute after administration. Then the paralytic agent pancuronium is given, followed by a fatal dose of potassium chloride. The judge found, however, that evidence from execution logs showed that 6 of the previous 8 prisoners put to death in California had not stopped breathing before technicians gave the paralytic agent. The finding raised a serious possibility that the prisoners had experienced suffocation from the paralytic, a feeling much like being buried alive, and felt intense pain from the potassium bolus. This experience would be unacceptable under the Constitution's 8th Amendment protections against cruel and unusual punishments. So the judge ordered the state to have an anesthesiologist present in the death chamber to determine when the prisoner was unconscious enough for a second and third injection to be given, or to have a general physician supervise an execution performed with sodium thiopental alone. This sounds a little odd to have doctors help with execution because their role is to save people instead of doing harm. So I wonder what the doctors would think about doing this kind of work. The California Medical Association, the American Medical Association, and the American Society of Anesthesiologists immediately and loudly opposed such physician participation as a clear violation of medical ethics code. Physicians are healers, not executioners, the ASA's president told reporters. Nonetheless, in just 2 days, prison officials announced that they had found 2 willing anesthesiologists. The court agreed to maintain their anonymity and to allow them to shield their identities from witnesses. Both withdrew the day before the execution, however, after the Court of Appeals for the Ninth Circuit added a further stipulation requiring them to personally administer additional medication if the prisoner remained conscious or exhibited pain. This they would not accept. The execution was then postponed. Morales remained on death row as of January 2007, but federal courts have since continued to require that medical professionals assist with the administration of any execution by lethal injection. Execution had become a medical procedure in the United States. The fact has forced a few doctors and nurses asked to participate in executions to choose between the ethical codes of their professions and the desires of broader society. The codes of medical societies are not always right, and neither are the laws of the society. There are vital but sometimes murky differences between acting skillfully, acting lawfully, and acting ethically. So how individual doctors and nurses have sorted these out and made their choices interested me. The Morales ruling is the culmination of a steady evolution in methods of execution in the United States. On July 2nd, 1976, in deciding the case of Gregg versus Georgia, the Supreme Court legalized capital punishment after a decade-long moratorium on executions. Executions resumed 6 months later, on January 17, 1977, in Utah, with the death by a firing squad of Gary Gilmore for the killing of Ben Bushnell, a Provo motel manager. Death by firing squad, however, came to be regarded as too bloody and uncontrolled. Gilmore's heart, for example, did not stop until 2 minutes after he was shot, and the shooters had sometimes weakened at the trigger, as famously happened in 1955 in Utah, when the 5 riflemen fired away from the target over Elysius Meyer's heart, only to hit his right chest and cause him to bleed slowly to death. Wow, this is very sad to read about how people get executed. If they were to suffer for a very long time, then I think that is kind of cruel, actually. Hanging came to be regarded as still more inhumane. Under the best of circumstances, the cervical spine is broken at the second vertebra, the diaphragm is paralyzed, and the prisoner suffocates to death, a minutes-long process. Gas chambers proved no better. Asphyxiation from cyanide gas, which prevents cells from using oxygen by inactivating a vital enzyme called cytochrome oxidase, took even longer than death by hanging, and the public revolted at the vision of suffocating prisoners fighting for air and then seizing as their abilities to use oxygen shut down. In Arizona, in 1992, for example, the asphyxiation of triple murderer Donald Harding took 11 minutes, and the sight was so horrifying that reporters cried, the Attorney General vomited, and the prison warden announced he would resign if forced to conduct another such execution. Since 1976, only 2 prisoners have been executed by firing squad, 3 by hanging, and 11 by gas chamber. Many more executions, 74 of the first 100 after Gregg and 153 in all, were by electrocution, which was thought to cause a swifter, more acceptable death. But officials found that the electrical flow frequently arsed, cooking flesh and sometimes igniting prisoners. Post-mortem examinations often had to be delayed for the bodies to cool, and yet in the case of some prisoners, it took repeated draughts to kill them. In Alabama in 1979, for example, John Louis Evans III was still alive after 2 cycles of 2,600 volts. The warden called Governor George Wallace, who told him to keep going, and only after a 3rd cycle, with witnesses screaming in the gallery, and almost 20 minutes of suffering, did Evans finally die. Only Florida, Virginia, and Alabama persisted with electrocutions with any frequency, and under threat of Supreme Court review, they too abandoned the method. Lethal injection now appeared to be the sole method of execution accepted by courts as humane enough to satisfy the 8th Amendment requirements, largely because it medicalizes the process. The prisoner is laid supine on a hospital gurney. A white bedsheet is drawn up to his chest. An intravenous line flows into his arm. Under the protocol devised in 1977 by Dr. Stanley Douche, the chairman of anesthesiology at University of Oklahoma, prisoners are first given 2,500 to 5,000 milligrams of sodium thiopental, 5 to 10 times the recommended maximum for ordinary therapeutic use, which can produce death all by itself by causing complete cessation of the brain's electrical activity, followed by respiratory arrest and circulatory collapse. Death, however, can take 15 minutes or longer with thiopental alone, and the prisoner may appear to gasp, struggle, or convulse. So 60 to 100 milligrams of pancuronium, 10 times the usual dose, is injected 1 minute or so after the thiopental to paralyze the prisoner's muscles. Finally, 120 to 240 milliequivalents of potassium is given to produce rapid cardiac arrest. Officials liked this method because it borrowed from established anesthesia techniques. It made execution more like familiar medical procedure than the grisly, backlash-inducing spectacle it had become. In Missouri, executions were even moved to a prison hospital procedure room. It was less disturbing to witness. The drugs were cheap and routinely available. Cyanide gas and 30,000-watt electrical generators, by comparison, were awfully hard to find, and officials could turn to doctors and nurses to help with technical difficulties, attest to the painlessness and trustworthiness of the technique, and lend a more professional air to the proceedings. But medicine balked. In 1980s, when the first execution was planned using Deutsch's method, the AMA passed a resolution against physician participation as a violation of core medical ethics. The resolution was quite general. It did not address, for example, whether pronouncing death at the scene, some doctors have done at previous executions, was acceptable or not. So the AMA clarified its ban in its 1992 Code of Medical Ethics. Article 202 states, "A physician, as a member of a professional dedicated to preserving life when there is hope of doing so, should not be a participant in a legally authorized execution." Although an individual physician's opinion about capital punishment remains the personal moral decision of the individual, the code further stipulates that unacceptable participation includes prescribing or administering medication as part of the execution procedure, monitoring vital signs, rendering technical advice, selecting injecting sites, starting or supervising placement of intravenous lines, or simply being present as a physician. Pronouncing death is also considered unacceptable because the physician is not permitted to revive the prisoner if he or she is found to be alive. Only two actions are acceptable: provision at the prisoner's request of a sedative to calm anxiety beforehand, and signing a death certificate after another person has pronounced death. The Code of Ethics of the Society of Correctional Physicians established an even stricter ban. The correctional health professional shall not be involved in any aspect of execution of the death penalty. The American Nurses Association has adopted a similar prohibition. Only the National Pharmacists Society, the American Pharmaceutical Association, permits involvement, accepting the voluntary provision of execution medication by pharmacists as ethical conduct. States, however, wanted a medical presence. In 1982, in Texas, the state prison medical director, Ralph Gray, and another doctor, Bascom Bentley, agreed to attend the country's first execution by lethal injection, though only to pronounce death. But once on the scene, Gray was persuaded to examine the prisoner to show the team the best injection site. Still, the doctors refused to give advice about the injection itself and simply watched as the warden prepared the chemicals. When he tried to push the syringe, however, it did not work. He had mixed all the drugs together, and they had precipitated in a clot of white sludge. "I could have told you that," one of the doctors reportedly said, shaking his head. After a second effort, Gray went to pronounce the prisoner dead, but found him still alive. The doctors were part of the team now, though. They suggested allowing more time for more drugs to run in. Today, all 38 death penalty states rely on lethal injection. Of 1,045 murderers executed since 1976, 876 were executed by injection. Against vigorous opposition from the AMA and state medical societies, 35 of the 38 states explicitly allow physician participation in executions. Indeed, 17 required it. Colorado, Florida, Georgia, Idaho, Louisiana, Mississippi, Nevada, North Carolina, New Hampshire, New Jersey, New Mexico, Oklahoma, Oregon, South Dakota, Virginia, Washington, and Wyoming. To protect participating physicians from license challenges for violating ethics code, states commonly promise anonymity and provide legal immunity from such challenges. Nonetheless, despite the promised anonymity, several states have produced the physicians in court to vouch publicly for the legitimacy and painlessness of the process. And despite the immunity, several physicians have faced license challenges, though none have lost as yet. States have affirmed that physicians and nurses, including those who are prison employees, have a right to refuse participation in any way in execution. Yet they have found physicians and nurses who are willing to participate. Who are these people? Why do they do it? It is not easy to find an answer to these questions. Medical personnel who help with executions are difficult to identify and reluctant to discuss their roles, even when offered anonymity. Among the 15 I was able to locate, however, I found 4 physicians and 1 nurse who agreed to speak with me. Collectively, they have helped with at least 45 executions. None were zealots for the death penalty, and none had a simple explanation for why they did this work. The role, most said, had crept up on them. Dr. A has helped with about 8 executions in his state. He was extremely uncomfortable talking about the subject. Nonetheless, he ultimately agreed to tell me his story. Almost 60 years old, he is board certified in internal medicine and critical care. He and his family have lived in their small town for 30 years. He is well respected. Almost everyone of local standing comes to see him as their primary care physician. The bankers, his field doctors, the mayor. Among his patients is the warden of maximum security prison that happens to be in his town. One day, several years ago, the 2 of them got talking during an appointment. The warden complained of difficulties staffing the prison clinic and asked Dr. A if he would be willing to see prisoners there occasionally. Dr. A said he would. He'd have made more money in his own clinic. The prison paid $65 an hour, but the prison was important to the community, and he liked the warden. And it was just a few hours of work a month. He was happy to help. Then, a year or 2 later, the warden asked him to help with a different problem. The state had a death penalty, and the legislature had voted to use lethal injection exclusively. The executions were to be carried out in the warden's prison. He needed doctors, he said. Would Dr. A help? He would not have to deliver the lethal injection. He would just help with cardiac monitoring. The warden gave the doctors time to consider the request. My wife didn't like it, Dr. A told me. She said, "Why do you want to go there?" But he felt torn. I knew something about the past of these killers. One of them had killed a mother of 3 during a convenience store robbery, and then, while getting away, shot a man who was standing at his car. Another convict had kidnapped, raped, and strangled to death an 11-year-old girl. I do not have a very strong conviction about the death penalty, but I don't feel anything negative about it for such people either. The execution order was given legally by the court, and morally, if you think about the animal behavior of some of these people. Ultimately, he decided to participate, he said, because he was only helping with monitoring. because he was needed by the warden and his community, because the sentence was society's order, and because the punishment did not seem wrong. I like this paragraph because the doctor said his reason of being okay with helping with execution is he is just following the laws of the society. He isn't trying to kill someone actively. So I think he made a reasonable justification. At the first execution, he was instructed to stand behind a curtain, watching the inmate's heart rhythm on a cardiac monitor. Neither the witness on the other side of a glass window nor the prisoner could see him. A technician placed 2 IV lines. Someone he could not see pushed the 3 drugs, one right after another. Watching the monitor, he saw the normal rhythm slow and then waveforms widen. He recognized the tall peaks of potassium toxicity, followed by the fine spikes of ventricular fibrillation, and finally the flat, unwavering line of asystolic cardiac arrest. He waited half a minute, then signaled to another physician, who went out before the witnesses, to place his stethoscope on the prisoner's unmoving chest. The doctor listened for 30 seconds, and then told the warden the inmate was dead. Half an hour later, Dr. A was released. He made his way through a side door, past the crowd gathered outside, to his parked car and headed home. In 3 subsequent executions, there were difficulties, though all with finding a vein for an IV. The prisoners were either obese or past intravenous drug users or both. The technicians would stick and after half an hour give up. This was a possibility the warden had not prepared for. Dr. A had placed numerous lines. Could he give a try? Okay, Dr. A decided. Let me take a look. It was a turning point, though he didn't realize it at the time. He was there to help. They had a problem, so he would help. It did not occur to him to do otherwise. In 2 of the prisoners, he told me, he found a good vein and placed the IV. In one, however, he could not find a vein. All eyes were on him. He felt responsible for the situation. The prisoner was calm. Dr. A remembered the prisoner saying to him, almost to comfort them, no, they can never get the vein. The doctor decided to place a central line, an intravenous line that goes directly into the chest. People scrambled to find a kit. I asked him how he placed the line. It was like placing one for any other patient, he said. He decided to place it in the subclavian vein, a thick pipe of vein running under the collarbone, because that is what he most commonly did. He opened the kit for the triple lumen catheter and explained to the prisoner everything he was going to do. I asked him if he was afraid of the prisoner. No, he said. The man was perfectly cooperative. Dr. A put on sterile gloves, gowns, and mask. He swabbed the man's skin with antiseptic. Why? I asked. Habit, he said. He injected a local anesthetic. He punctured the vein with 1 stick. He checked to make sure he had a good, non-pulsatile flow of dark venous blood coming out. He threaded a guide wire through the needle, a dilator over the guide wire, and finally slid the catheter in. All went smoothly. He flushed the lines with saline lime, secured the catheter up to the skin with a stitch, and put a clean dressing on it, just as he always does. Then he went back behind the curtain to monitor the lethal injection. Only 1 case seemed to really bother him. The convict who had killed a policeman weighed about 350 pounds. The team placed his intravenous lines without problem, but after they had given him all 3 injections, the prisoner's heart continued. It was an agonal rhythm, Dr. A said, a rhythm with a widened appearance on the EKG, going only 10 or 20 beats per minute. He was dead, he insisted. Nonetheless, the rhythm continued. The team looked to Dr. A. His explanation of what happened next diverged from what I learned from another source. I was told that he instructed that another bolus of potassium be given. When I asked him if he did, he said, "No, I didn't." As far as I can remember, I didn't say anything. I think it may have been another physician. Certainly, however, all boundary lines have been crossed. He had agreed to take part in the execution simply to watch our cardiac monitor, but just by being present, by having expertise, he had opened himself to being called out to do steadily more, to take responsibility for the execution itself. Perhaps he was not the executioner, but he was darn close to it, and he seemed troubled by that. I asked him whether he had known that his actions, everything from the monitoring of the execution to helping officials with the process of delivering the drugs, violated the AMA's ethics code. I never had any inkling, he said, and indeed, the only survey done on this issue in 1999 found that just 3% of doctors knew of any guidelines governing their participation in execution. The humaneness of a lethal injection Dr. A was involved in was challenged in court. However, the state summoned him for a public deposition on the process, including the particulars of the execution, in which the prisoner required a central line. His local newspaper printed the story. Word spread through his town. Not long after, he arrived at work to find a sign pasted to his clinic door, reading, "The Killer Doctor." A challenge to his medical license was filed with the state. If he wasn't aware earlier that there was an ethical issue at stake, he was now. 90% of his patients supported him, he said, and the state medical board upheld his license under a law that defined participation in execution as acceptable activity for a physician. But he decided he wanted no part of the controversy anymore and quit. He still defends what he did. Had he known of the AMA's position, though, I would never have gotten involved, he said. So here is another doctor who got involved with execution. Dr. B spoke to me between clinic appointments. He is a family physician, and he has participated in some 30 executions. He became involved long ago, when electrocution was the primary method, and then continued through the transition to lethal injection. He remains a participant to this day, but it was apparent that he had been more cautious and reflective about his involvement than Dr. A had. He also seemed more troubled by it. Dr. B, too, had first been approached by a patient. One of my patients was a prison investigator, he said. I never quite understood his role, but he was an intermediary between the states and its inmates. He was hired to monitor that the state was taking care of them. They had the first 2 executions after the death penalty was reinstated, and there was a problem with the second one, where the physicians were going in a minute or so after the event and still hearing heartbeats. The 2 physicians were doing this out of courtesy because the facility was in their area. But the case unnerved them to the point that they quit. The officials had a lot of trouble finding another doctor after that, so that was when my patient talked to me. Dr. B did not really want to get involved. He was in his 40s then. He had gone to a top-tier medical school. He had protested the Vietnam War in the 1960s. I've gone from a radical hippie to a middle-class American over the years, he said. I wasn't on any bandwagons anymore. But his patient said the team needed a physician only to pronounce death. Dr. B had no personal objection to a capital punishment. So in the moment, it was a quick judgment, he agreed, but only to do the pronouncements. The execution was a few days later by electric chair. It was an awful sight, he said. They say an electrocution is not an issue, but when someone comes up out of that chair 6 inches, It's not for nothing. He waited a long while before going out to the prisoner. When he did, he performed a systemic examination. He checked for carotid pulse. He listened to the man's heart 3 times with a stethoscope. He looked for a pupil response with his pen light. Only then did he pronounce the man dead. He thought harder whether to stay involved after the first time. I went to the library and researched it, and that was when he discovered the 1980 AMA guidelines. As he understood the code, if he did nothing except to make a pronouncement of death, he would be acting properly and ethically. It was before the 1992 AMA clarification that made pronouncing death at the scene a clear violation of the code, but allowed signing a death certificate afterward. Knowing the guidelines reassured him about his involvement and made him willing to continue. It also emboldened him to draw thicker boundaries around his participation. During the first lethal injections, he and another physician were in the room when they were administering the drugs, he said. We could see the telemetry, the cardiac monitor. We could see a lot of things, but I had them remove us from that area. I said, I do not want any access to the monitor or the EKGs. A couple times they asked me about recommendations in cases in which there were venous access problems. I said, no, I'm not going to assist in any way. They would ask about amounts of medicines. They had problems getting the medicines, but I said I had no interest in getting involved in any of that. So this doctor seemed a lot more conscious about what is going on, and he has set himself clear guidelines to not get involved in anything that would be considered unethical. Dr. B kept himself at some remove from the execution process, but he would be the first to admit that he is not an ethically pristine position. When he refused to provide additional assistance, the execution team simply found others who would. He was glad to have those people there. If the doctors and nurses are removed, I don't think lethal injections could be competently or predictably done. I can tell you I wouldn't be involved unless these people were involved. I agonize over the ethics of this every time they call me to go down there, he said. His wife knew about his involvement from early on, but he could not bring himself to tell his children until they were grown. He had let almost no one else know. Even his medical staff is unaware. The trouble is not that the lethal injections seemed cruel to him. Mostly they were very peaceful, he said. The agonizing came instead from his doubts about whether anything is accomplished. The whole system doesn't seem right, he told me toward the end of our conversation. I guess I see more and more executions, and I really wonder. It just seems like the justice system is going down a dead-end street. I can't say that lethal injection lessens the incidence of anything. The real depressing thing is that if you don't get to these people before the age of 3 or 4 or 5, it's not going to make a difference in what they do. They've struck out before they even started kindergarten. I don't see executions as saying anything about that. The medical people most wary of speaking to me were those who worked as full-time employees in state prison systems. Nonetheless, 2 did agree to speak. One a physician in a southern state prison, and another a nurse who had worked in a prison out west. Both seemed less conflicted about involved in execution than Dr. A and Dr. B. The physician, Dr. C, was younger than the others and relatively junior among his prison doctors. He did not trust me to keep his identity confidential, and I think he worried for his job if anyone found out about our conversation. As a result, although I had an independent information that he had participated in at least 2 executions, he would speak only in general terms about the involvement of doctors. But he was clear about what he believed. I think that if you're going to work in the correctional setting, Participating in executions is potentially a component of what you need to do. He said, it is only a tiny part of anything that you're doing as a part of your public health service. A lot of society thinks these people should not get any care at all. But in his job, he must follow the law and it obligates him to provide proper care, he said. It also has set the prisoner's punishment. 13 jurors, citizens of the state, have made a decision. And if I live in that state and that's the law, then I would see it as being an obligation to be available. He explained further, I think that if I had to face someone I love being put to death, I would want that to be done by lethal injection, and I would want to know that it is done competently. The nurse saw his participation in fairly similar terms. He had fought as a Marine in Vietnam and later became a nurse. As an Army reservist, he served with a surgical unit in Bosnia and then in Iraq. He worked for many years on critical care units, for almost a decade as nurse manager for a busy emergency department. He then took a job as the nurse in charge of his state penitentiary, where he helped with one execution by lethal injection. It was the state's first execution by this method, and at the time there were great naivety about lethal injection, he said. No one in the state had any idea what was involved. The warden had a protocol from Texas and thought it looked pretty simple. What did he need medical personnel for? The warden told the nurse that he would start the IV himself, though he had never started one before. Are you, as a doctor, going to let this person stab the inmate for half an hour because of his inexperience? The nurse asked me. I wasn't, he said. I had no qualms. If this is to be done correctly, if it is to be done at all, then I am the person to do it. It is not to say that he felt easy about it, however. As a Marine and as a nurse, I hope I will never become someone who has no problem taking another person's life. But society has determined that punishment and had done so carefully with multiple judicial reviews, he said. The convict had killed 4 people, even while in prison. He had arranged for an accomplice to blow up the home of a county attorney he was angry with, while the attorney, his wife, and their child were inside. When the accomplice turned the state's evidence, the inmate arranged for him to be tortured and killed at a roadside rest stop. The nurse did not disagree with the final judgment that this man should be put to death. The nurse took his involvement seriously. As the leader of the healthcare team, he said, it was my responsibility to make sure that everything be done the way that was professional and respectful to the inmate as a human being. He spoke to an official with the state nursing board about the process, and although involvement is against the ANA's ethical guides, the board said under state laws he was permitted to do everything except push the drugs. So he issued a purchase request to the pharmacists supplying the drugs. He did a dry run with public citizens chosen to push the injections and with the guards to make sure they knew how to bring the prisoner out and strap him down. On the day of the execution, the nurse dressed as if for an operation, in scrubs, mask, hat, and sterile gown and gloves. He explained to the prisoner exactly what was going to happen. He placed 2 IVs and taped them down. The warden read the final order to the prisoner and allowed him his last words. He didn't say anything about his guilt or his innocence, the nurse said. He just said that the execution made all of us involved killers just like him. The warden gave the signal to start the injection. The nurse hooked the syringe to the IV port and told the citizen to push the sodium thiopental. The inmate started to say, "Yeah, I can feel," and then he passed out. They completed the injections. 3 minutes later, he flatlined on cardiac monitor. The 2 physicians on the scene had been left nothing to do except to pronounce the inmate dead. I have personally been in favor of the death penalty. I was a senior official in the 1992 Clinton presidential campaign and in the administration, and in that role, I defended the president's stance in support of capital punishment. I have no illusions that the death penalty deters anyone from murder. I also have great concern about the ability of our justice system to avoid putting someone innocent to death. However, I believe there are some human beings who do such evil as to deserve to die. I am not troubled that Timothy McVeigh was executed for the 168 people he killed in the Oklahoma City bombing, or that John Wayne Gacy was for committing 33 murders. Still, I hadn't thought much about exactly how the executions are done, and I have always instinctively regarded involvement in execution by physicians and nurses as wrong. The public has granted us extraordinary and exclusive dispensation to administer drugs to people, even to the point of unconsciousness, to cut them out open, to do what would otherwise be considered assault, because we do so on their behalf, to save their lives and provide them comfort. To have the state take control of these skills for its purposes against a human being, for punishment, seemed a dangerous perversion. Society has trusted us with powerful abilities, and the more willing we are to use these abilities against individual people, the more we risk and betray the trust. My conversations with the physicians and the nurses I had tracked down, however, rattled both on these views, and no conversation more so than I had with the final doctor I spoke to. Dr. D is a 45-year-old emergency physician. He is also a volunteer medical director for a shelter for abused children. He works to reduce homelessness. He opposes the death penalty because he regards it as inhumane, immoral, and pointless, and he has participated in 6 executions so far. About a decade ago, a new jail was built down the street from the hospital where he worked, and it had a large infirmary, the size of our whole emergency room. The jail needed a doctor, so, out of curiosity as much as anything, Dr. D began working there. I found that I loved it, he said. Jails are an underserved niche of healthcare. Jails, he pointed out, are different from prisons in that they house people who are arrested and waiting trial. Most are housed only a few hours to days and then released. The substance abuse and non-compliance is high. The people have a wide variety of medical needs. It is a fascinating population. The setting is very similar to the ER. You can make a tremendous impact on people and on public health. Over time, he shifted more and more of his work to the jail system. He built a medical group for the jails in his area and soon became an advocate for correctional medicine. In 2002, the doctors who had been involved in executions in his state pulled out. Officials asked Dr. D if his group would take the contract. Before answering, he went to observe an execution. It was a very emotional experience for me, he said. I was shocked to witness something like this. He had opposed the death penalty since college, and nothing he saw made him feel any different. But at the same time, he felt there were needs that he, as a correctional physician, could serve. He read about the ethics of participating. He knew about the AMA's stance against it. Yet he also felt an obligation not to abandon inmates in their dying moments. We, as doctors, are not the ones deciding the fate of this individual, he said. The way I saw it, this is an end-of-life issue. just as with any other terminal disease. It just happened that it involves a legal process instead of a medical process. And when we have a patient who can no longer survive his illness, we as physicians must ensure he has comfort. A death penalty patient is no different from a patient dying of cancer, except his cancer is court-ordered. Dr. D said he had the cure for this cancer, abolition of death penalty. But if the people and the government won't let you provide it, and a patient then dies, are you not going to comfort him? His group took the contract, and he has been part of the medical team for each execution since. The doctors are available to help if there are difficulties with the IV access, and Dr. D considered it their task to ensure that the prisoner is without pain or suffering through the process. He himself provides the cardiac monitoring and the final determination of death. Watching the changes on the two-line electrocardiogram tracing, I keep having that reflex as an ER doctor, wanting to treat that rhythm, he said. Aside from that, his main reaction is to be sad for anyone involved. The prisoner whose life has led to this, the victims, the prison officials, the doctors. The team's payment is substantial, $18,000, but he donates his portion to the children's shelter where he volunteers. I've never thought that doctors can be paid a lot of money by executing prisoners, and I'm very glad to read that he's donating money to children's shelter, because I really like working with children, and I think that by providing the children the best resources they have, they would be a lot less likely to become people who need help in life, and people who might do good things if they were treated well as kids. 3 weeks after speaking to me, he told me to go ahead and use his name. It's Carlo Masso. He helps with executions in Georgia. He didn't want to seem as if he were hiding anything, he said. He didn't want to invite trouble either, but activists have already challenged his license and his membership in the AMA, and he is resigned to the fight. It just seems wrong for us to walk away, to abdicate our responsibility to the patient, he says. There is little doubt that lethal injection can be painless and peaceful, but as courts have recognized, ensuring that it is requires significant medical assistance and judgment for placement of intravenous lines, monitoring of unconsciousness, and adjustment in medication timing and dosage. In recent years, medical societies have persuaded 2 states, Kentucky and Illinois, to pass laws forbidding physician participation in executions. Nonetheless, officials in each of these states intend to continue to rely on medical supervision, employing nurses and nurse anesthetists instead. How, then, to reconcile the conflict between government efforts to provide a medical presence and our ethical principle forbidding it? Are our ethics what needs to change? The doctors' and nurses' argument for competence and comfort in the execution process certainly have force, and they gave me pause. But however much these practitioners may wish to comfort a patient, it ultimately seems clear to me that the inmate is not really their patient. Unlike genuine patients, the inmate has no ability to refuse a patient's care. Indeed, the inmate and his family are not even permitted to know the physician's identity, and the medical assistance provided primarily serves the government's purposes, not the inmate's needs and interests as a patient. Medicine is being made as an instrument of punishment. The hand of comfort that more gently places the IV, the more carefully times the bolus of potassium, is also the hand of death. We cannot escape this truth. The truth is what convinces me that we should stand with the ethics code and legally ban the participation of physicians and nurses in execution. And if it turns out that executions cannot be performed without, as the court puts it, unconstitutionally painful and cruel, the death penalty should be abolished. It is far from clear that a society that punishes its most evil murderers with life imprisonment is worse off than one that punishes them with a death. But a society in which the government actively subverts core ethical principles of medical practice is patently worse off for it. The U.S. government has shown willingness to use medical skills against individuals for its own purposes, having medical personnel assist in the interrogation of prisoners, for example, adjust their medical documentation and death certificates, place feeding tubes for force feeding them, and help with executing them. As our abilities to manipulate the human body advance, government interest in our skills will only increase. Preserving the integrity of medical ethics would not be more important. I very much agree with what he is saying. The government should not have so much power over what doctors can do with their healing skills. So I think the author here is making a good point. The 4 physicians and the nurse I spoke to all acted against long-standing principles of their professions. Their individual actions have rendered those principles effectively irrelevant. As long as a prison can count on a handful of doctors and nurses helping with executions, the ethics of many do not matter. Yet it must be said, most of those I interviewed took their moral duties seriously. It is worth reflecting on this truth as well. The easy thing for any doctor or nurse is simply to follow the written rules, but each of us have a duty not to follow rules and laws blindly. In medicine, we face conflicts about what the right and best actions are in all kinds of areas. Relief of the suffering for the terminally ill, provision of narcotics for patients with chronic pain, withdrawal of life-sustaining treatment for critically ill, abortion, and executions, to name just a few. All have been the subject of professional rules and government regulation, and at times those rules and regulations have been and will be wrong. We may then be called on to make a choice. We must do our best to choose intelligently and wisely. Sometimes, however, we will be wrong, as I think the doctors and nurses who have used their privileged skill to make possible 876 deaths by lethal injection thus far. We each should then be prepared to accept the consequences. Above all, we have to be prepared to recognize when using our abilities skillfully comes into conflict with using them rightly. Assistance with execution is a stark instance, but it is far from the only one. Indeed, it's not even the most difficult one. And that is the end of the chapter, called The Doctors of the Death Chamber. It is a very interesting chapter discussing whether doctors should be allowed to assist in lethal injections of prisoners, and only at the end did the author review that he supports not letting doctors to be a part of this process. I enjoyed reading about his reasoning, and it has made me a lot more conscious about all sorts of ethical problems out there in the world. And next time we'll continue reading the next chapter. Thanks for being with me today.